Good morning, everyone. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX. We're delighted to welcome you to another community conversation. It's March 13, 2023. And before we start, I would like to just first acknowledge that HealthAdvocateX is headquartered in Seattle, Washington, and we acknowledge that we're on the traditional land of the first people of Seattle, the Duwamish people, past and present, and honor with gratitude the land itself and the Duwamish tribe. We invite you to join us in acknowledging and thanking Indigenous people for their ongoing stewardship wherever you are located. And we would also like to open this meeting as a safe space. And what that means is that every person's voice will be heard and respected. And we know that we all come from different lived experiences, so there is potential to cause unintentional harm. We as an organization, HealthAdvocateX, are committed to repairing any unintentional harm should it occur. So we're really happy to be continuing to host these conversations. And as many of you know who have participated in this call for the last 3 years, we do make this available and free to the public. Today, we're going to be talking about COVID-19 updates with Dr. Dale Reisner. And then we will be joined also with Danielle Marshall, with Danielle Marshall, who's the executive director of the Patient Advocate Certification Board. Many of you have a BCPA credential, and we'll be talking about how the new Justice, Equity, Inclusion, and Diversity and Inclusion CE is going to be working, and a bit about why health advocacy is really focusing on diversity, inclusion, equity, access, and justice issues. So with that, I'd like to turn it over to Dale, and I just want to remind everyone that if you do have questions, throw them in the chat. We'll be having a conversation. I'll be monitoring the chat. And then obviously the speakers will give their presentations, and then we'll invite your questions. So with that, I'd like to turn it over to Dale.
Good morning, everybody. And I wanted to say hi. I think most of you have been here before. Anyone who hasn't, I was recently, for the last 32 years, working within a hospital system for quality improvement within the obstetric arena. And part of the work I did was across all fields in simulation in healthcare. And it has really given me a broad perspective of how infections like COVID and other diseases affect people across their lifespan, across gender, and particularly within the discrepancies that we see for outcomes for race, ethnicity, and other populations that have biases against them, where access to care, they may have insurance, but they don't necessarily have a comfortable access to care. So I'm really excited to hear Danielle talking about their work on this topic. And I'm going to give a little bit of update for COVID, but really try to keep most of the time available to her, always accessible to questions after she presents as well. So where we are with our cases is globally over 759 million, with over 6.8 million deaths, and these are confirmed cases. So we know there's more than this. In the US, it's greater than 100 million cases with greater than 1.1 million deaths. So we are continuing. If you were on last month, I think it was last month that, or possibly January, where I talked about the death rate from COVID at this point in time is running around 1%. And this is higher than what we see from flu, but it's much lower than what we were seeing initially when the first cases were happening in very susceptible age groups and people with underlying medical conditions. a little bit about vaccination. And just so you know, you probably feel this and have heard it, but case rates have gone down across the country. There are some hot spots. Interesting, when we're going to talk a little bit about vaccination and masking, but sadly, but not surprisingly, many of the cases that are in the medium to high levels are in places that have declined to to vaccinate themselves, and also are not doing social distancing and not masking. The places where it's highest right now in the mid to high range are Montana and part of eastern Idaho, Florida, and spots across the Midwest. It's not fully concentrated in any one state, but scattering across the Midwest. About 82%, this is the good news, about 82% of the counties across the US have low levels of COVID right now. So that is huge. And that has, I think, made people be more resistant to isolation, the social distance. I always like the physical distancing rather than social distancing.
Yeah, I like that too.
Yeah. And because you could be socially connected with a phone or with a meeting like this. So those things, masking, et cetera, are less on people's minds, and you will see this wherever you go. And some places in healthcare even are falling back on that. Now, direct patient care, that's not the case. But I've noticed, I've done a little bit of traveling across the country this year, and I've noticed that in waiting rooms, people are not automatically being required to wear masks, which is quite interesting to me.
Do they track like community acquired COVID infection? Is that like a thing?
Oh, it is. And if you travel, you can actually sign in for statewide or your region where you are to see if there's any recent COVID cases. But it's all done, the tracking is really done right now, mostly, well, with reported cases for sure, but mostly reliably with wastewater assessment, because so many people are getting COVID, testing at home, and they're providers and hospitals don't know anything about it unless they reach out for, if you're in a high risk category, and reach out for Paxlovid or something like that, which I'll talk about briefly. It is good that most places have low levels for sure. And it still speaks to how you as an individual and how your clients that you're advocating for need to protect themselves when they go into public places. The vaccination rate is very interesting because the overall vaccination rate for 1 or 2 shots is quite good across our country. The booster rate is low. When you look at, and this, they're doing the vaccination data a little less frequently. So this is through the end of February. Over 672 million doses have been given in the US, but some of those are for people like me that have had 4, so when you look at the overall percentage, so there's 332 million population in the US, 332 million, a lot of people. 81% of those have had at least 1 shot. 66% have had the second. So that at least 1 might be the J&J that was only 1 shot anyway, and also might be only 1 dose of the 2 dose recommended, either Pfizer or Moderna. So that's quite good, really. And Robin wanted me to mention the vaccination stuff. I'll put it in right now. Vaccination versus wild disease antibody protection. Nobody knows if one is better than the other. They look like they might be comparable from the comparisons that I'm seeing. It is anticipated that you may get about 10 months worth of protection out of wild disease COVID infection. And we're still trying to accumulate data on the vaccinations because the variants have changed so much, and the vaccinations specifically targeting Omicron were only out not even a year ago. So I think that we will see more about that, and we will hear more about that and any ongoing recommendations for boosters in the fall as we continue to collect that information.
So you think the booster will be in the fall, not before that?
Yes.
Okay.
Yes. There's
So
no
like a once a year. Yeah.
Yeah. No suggestion that they're coming out with another booster. The
Mhm.
booster that was put out this last fall is quite effective against the Omicron variants. And as you know, they've changed over time. The lower the disease rates, the less we're going to see that. So the more predictable the effectiveness of the vaccine will be if we're still dealing with the types of variants that we have this spring. So they will take that Omicron booster, just so you know how this works, and they will look at what it covers well, and they will look to see if there are very infectious and deadly variants that are out that they should be adding to that or modifying that. And then that will be
like the flu vaccine, right?
Kind of like the flu vaccine. They'll be able to do that. Yeah. So I think that that's mostly what I'm going to talk about vaccination. And then I wanted to do a couple of updates before I hand the rest of the discussion over to Danielle. When Evusheld was a pre-exposure monoclonal antibody combination that was given emergency use accessibility by the FDA for people who are immunocompromised and who may not mobilize enough antibody from either the vaccine or if they had the wild disease. And it worked really well against the Delta and the original variants, but it does not work with the Omicron variants, which is the bulk of what's out there right now. So more than 90% of the Omicron and the newer variants, the Evusheld was not effective for. It's expensive. It's got some side effects. It's an injection. And so it's been taken off the market. We've had a brief discussion about Evusheld, I think probably 6 months ago or so from this community conversation. So I just wanted to give that update. If you have clients or anybody who's been taking it, I think knows that, but if you have clients that were potentially taking it, there are conversations about COVID rebound and Paxlovid rebound. So Paxlovid is a medication that works really well. And has very little contraindications. There are some, so it's not for everybody. Works really well against the Omicron variants. It's once you have the disease, once you test positive within 3 days of getting that diagnosis, within 5 days max, but ideally within 3 days of that positive test if you're in a high risk category. So that might be age, that might be medical conditions, you name it. The original study with Paxlovid, and really where Paxlovid is the most effective, it is 89% effective in preventing hospitalization and death. So those are the things we're not, you may not.
Amazing. Yeah. I mean, boom.
Yeah.
Okay.
And, knowing that it's being used in high risk populations. So we don't want people to be afraid of rebound with Paxlovid when not taking the Paxlovid may end up with a hospitalization, a severe illness and or death. And so really the comparison now is a little better. When they did the first study, it was fairly small. They had about a 2% rebound that went along with Paxlovid. In reality, as it's used more broadly across the population, we see this quite frequently with medications and even with the natural disease. A wild virus COVID infection has at least a 10% rebound. Okay. rebound is common with many of these viruses, particularly this the SARS family of viruses. And that includes the common cold. We don't think about it that much, but you may have really bad and then you get better and then you still have this ongoing runny nose or whatever, right?
And Lee said, can you just explain again for everybody what rebound actually looks like with Paxlovid?
So what rebound looks like with Paxlovid is probably more obvious than with the natural COVID infection. Paxlovid you take for 5 days. Now, I actually don't know why they decided 5 days, but that's the recommendation, 2 pills a day for 5 days. It does give you a really nasty taste. I took it. It's kind of a metallic taste in your mouth. It's not horrible. The pills, when you stop them, you may have a couple of days, 2-3 days of feeling better and testing negative. And then you may start feeling worse again. And so what the theory is with the medication rebound is that it's actually really effective in keeping that virus either under control or not replicating. So that's where you get the negative test from. And then in some cases, it may be that we should be treating longer than 5 days. And I think scientists are looking at this. And others are that it's just the way the virus works, even with the wild disease, and you're going to get some of that. So I think that that information needs to get out to people who are high risk so that they're not afraid to take Paxlovid and they jump on access to it if they're high risk in the first place and they don't have a contraindication.
And how is access going? Like I heard that because you have to do it kind of fast. So is there any way to be like prepped and prepared just in case?
I don't think so. I mean, you could check with your primary care provider and say, what if I do get COVID? What's the process? And be prepared that way. Yeah. You're not going to stock up on Pax. I mean, it's not cheap, but it's not expensive. And you're not going to stock out on it and keep it in your, cupboard or anything like that. So I do think it's it can be, if you have trouble getting into your primary care provider or your specialist, then yes, you may have a delay. And then the moment I would think about whether you want to take it ahead of time, kind of know the process for your caregiver team, and then you should be fine. If you're waiting till the very last minute to decide whether you want it, you may have trouble getting a hold of it right away.
Yeah. And I do want to mention Michael Wood asks, how much protection is afforded today? I don't know if you can answer this, to those with 2 to 4 shots 6 months to 2 years ago. The current boosters reported to wane significantly after only 10 weeks. So the question is, I think you might have addressed this kind of earlier.
I don't think we have enough information because our booster, and I didn't really look at the numbers, but across the country, our booster rate is only about 14%. So I do not think we have enough numbers on that. I am anticipating that we will get much better data about all the vaccination durations, whether it's a single set or with boosters over the next year. But I think right now it's really hard to say. There was a very interesting study. I think last month I talked about exercise enhancing your protection. And there was an interesting study about about all people who got poor sleep the night before they got vaccinated. And in men, they did not get as good of an immune response when they looked at their antibody response to their vaccination. So
wow, that's interesting.
Sure what that's all about, but there are a lot of factors that affect that. How you respond to vaccination. So I think early in the beginning of the vaccine, people were saying, don't take Tylenol before your vaccination. If you get symptomatic afterwards, of course, take it, but you may decrease the your body's immune response if you have already tempered something down. So I think that is, we'll see more, I'm sure, about this and see whether that's even replicable. But
yeah. Interesting.
yeah.
Okay.
And then the one other thing I want to talk about is you may have heard about a mask controversy. So I'm going to start with, because the folks of you on the line may not know very much about Cochrane reviews. So Cochrane is a group of investigators who will often take a topic and see what all has been published about it. They will review the studies, see the quality of the studies, and they have a whole grading system, look at whether the studies are comparable enough to blend them, and look at that composite data, because there are many things that we deal with in medicine that that are small studies, and you can't possibly do a full randomized control trial, or it would take 10 years to get the data you want. And so they're really considered the gold standard because they're meticulous about their methods. So they looked at masking. And they looked at masking in general for infection prevention, not necessarily for COVID only. And they started with 78 studies. Hang on here, let me get the numbers right for you. 78 studies, and only 10 of those really focused on if you wear masks and don't wear masks. So some of the studies looked at combination of masking, hand washing, distancing, and the masking was not the primary outcome. And so really what it boiled down to was there were only 2 or 3 studies that were good enough to give us any information. And the problem was their conclusion with this study that got published a few months ago, end of the year, was that the data was inconclusive. But the way they said that made it sound like it's not clear that masking works. So big to do about that, because they had weaned down all these studies to these few studies. And here's the biggest problem. And now people have gone back to them and interviewed them and said, yeah, we could have worded it better, blah, blah, blah. So really they are accepting that they were misleading. There's only one study that was pre-pandemic that looked at whether masking versus not masking reduced the spread of infection. And that was done in H1N1 season in 2009 in Germany. And they found that mask wearing reduced the spread if it started quickly and if the mask was worn consistently. And this is the biggest problem, because the studies, even the 2 studies other than this that were looking at not sure if it works, only 50% of the people who were supposed to wear masks wore them, and 24% of the people who weren't supposed to wear more masks wore masks. So there was not anywhere valid data in that study to compare these 2 groups. There was a slight improvement in protection in the mask group, but not very dramatic. And so, if you look at masking by itself, there is data from other countries where they have lower rates of community acquired flu and things like that, that just people start masking up in flu season. Hong Kong is an example, but it's not meticulous studies. And so I think you really need to look at this. And as I mentioned in the beginning, if you're going out in public with a lot of other people around and you don't want to get COVID, I would mask.
So Kim McElnay just posted the review of the Cochrane review in the chat. But just to be super uber clear, Dale, what you're saying is the Cochrane reviewers mistakenly stated that there was no difference.
No.
And the data does show that masking is effective. Can you
What they said was there's not enough data to say that masks work.
Mhm.
And so that's not
Quite
overtly
true?
inaccurate,
Yeah,
but it's
okay.
not quite true, because there's not, what they should have said is that really, we did this review and really there's only one study that shows a slight improvement, and
Mhm.
all the rest of them are worthless. That's what they
Mhm.
should have said. Yeah, that nobody's done the study that we need that has good mask adherence, and you
Mhm.
wouldn't have 100%. I mean, there was a study with students where they were told to wear masks for 6 hours in their dorms, but not told to wear masks in classrooms. That doesn't even make sense. So there's
Maggie
yeah,
Buckley just posted the clarification from Cochrane, so
perfect,
that's good.
perfect.
Thank you.
Yeah, if
And
you
I
want
want
that.
to, yeah,
Yep,
and I want to make sure that we get enough time with Danielle as
exactly.
well.
Exactly.
So
So
thank
that
you
was the
for,
end of my,
Mhm.
controversial stuff.
Yeah, yeah. But we know that masking works, so that's the bottom line. So, and for any of you who are advocates who you've been hearing from clients or others that we really don't know, here in the chat is some good clarification and evidence just to support ongoing support for masking, because we know that that is helpful. Okay, with that, so we'll have an opportunity to ask more questions of Dale in a moment, but I wanted to make sure that we heard from Danielle Marshall next from PAC-B, and she's going to tell us about the great work that PAC-B has been doing on a wide variety of areas. Danielle?
Thank you, Robin. Thank you all very much for inviting me and having us today. And we're really appreciative of the opportunity to share some data and also some of the work that the PAC board has been working on. So I wanted to start actually by going back to a study that HealthAdvocateX was involved in back in 2015 that they worked on with AFA, I think it was. Robin, is that correct?
It was Trish Torrey, Beth
Torrey.
Droppert, and myself. Yeah,
Okay. So anyway, it was just sort of the beginning. The exam wasn't even available at that point. But even then, we recognized that the majority of the demographics were, it was 93% female that were responding to the survey, 70% were over 55, 84% were white women. So at least we have a baseline. We knew what we were dealing with back in the beginning. And so when the exam started taking place, we actually collect demographics on every cohort of folks that take the exam, whether they pass or fail. And we found it was essentially the same. And then in 2021, we conducted the first official job analysis study, and that's a study that's a formal study that's required for all certification bodies to establish the knowledge, skills, abilities, tasks that are required to do a particular job or profession. And that year we found it was a little bit better in terms of the male female. We had 82% female, but we were 87% white. And we were older. We were 78% over 55. So
wow. And what year was that again?
That was in 2021.
2021. Okay.
So 2021 actually turned out to be a really pivotal year for all of us in terms of the work that started to take place. I think that the recognition was there and a lot of work really started to take place. And one of the first really significant activities that happened was the collaborative task force that was formed between HealthAdvocateX, NAC, and PACB. And the role of that particular task force was to evaluate the ethics documents that each organization was currently using as the definition of the ethics associated with being a patient or a healthcare advocate. And the goal was to prepare a single document that we could all sign off on and that we could also put out to any other organization that was working in that area and ask them to sign on as well. And there were really two key things, I think, that were significantly different in that revised collaborative document. One, of course, was the addition of some technology safeguards that were probably not even on the radar when some of those original documents were created. And so that was a sort of a new area. But really, one of the most significant parts of the document was the very intentional focus on adding or emphasizing the importance of the justice, equity, diversity, and inclusion component. And so that document has been finalized, formalized, approved by all the organizations, and is on everyone's website, and is also available for any other organization to sign on to if they wish to indicate that they support and agree with that document. So that was sort of a good first big step in that direction. And then at about the same time, in 2021, the board of directors for PACB really set out to establish a formal strategic framework for our focus areas. And one of those key areas, there were 5 areas, and one of those key areas was the specific identification of diversity and inclusion activities, goals, and initiatives. And one of the first areas, of course, was to increase diversity, equity, and inclusion amongst the board certified patient advocates that are out there working with their clients and families, but also for the leaders and the volunteers that are a significant part of the work that we all do. And we also recognize that diversity inclusion for our purposes, from the certification body's purposes, also extended to a few other more tangential areas in terms of how the certification can better meet the needs of other populations that are serving in more unique advocacy roles, such as the military, VA, and the international community. We still have a lot of interest internationally, and of course, those that are serving very specifically marginalized populations. And then the final goal that was established in that area was to create a scholarship program to support the efforts of those folks that wanted to be certified, but for whatever reason were not able to reach that goal.
How much does it cost to take the exam?
The exam is $395. That's the application to sit for the exam and the exam sitting fee. It's only just one fee altogether.
Because the scholarship applies to that, correct?
Scholarship would allow a person to sit for the exam at no cost.
Yeah.
So the important thing here also is to remember that the exam is built on the 6 domains of competency and the ethical standards, with the ethical standards being the largest percentage area on which the candidate is tested. 22% of the exam is in the area of ethics. And so one of the first things that the commissioned, Heidi Kummer, who is the chair of the exam or the certification commission, was to add a minority representation on the exam committee, such that they could review all of the items, both the entire item bank. So the item bank includes both the active items that are currently on the exam. It also includes pilot items, meaning those that they're testing for future versions of the exam, and retired items that are no longer in use and may be used in practice exams or other kinds of training and study materials. And one of the most important things they did was to review the exam, reviewed all the items for bias that any of those potential audiences might find difficult to answer, because it was written from essentially an old white woman's perspective that wanted to broaden that to be more inclusive. They also have gone through and gender neutralized, such that we're less focusing on the he, she, and more generic, less gender specificity. And I'm missing something. There's something else. It'll come to me in a second. But anyway, those were the main things. And then we added items to assess for knowledge of those DEI concepts, and have really actually learned or discovered that a lot of our advocates, our candidates that are taking the exam do not know much in that area. And that's a big area that we really need to still do a lot of education, because it tends to be a very poorly, those items tend to be answered much more poorly than many other items on the test. We also, and the other thing we did was we changed the format from a 4-answer option to a 3-answer option, which is statistically known. Many other boards have recently moved from a 4-answer to a 3-answer. If you look at the statistical performance on the exam, you can see that one of the 4-answer options almost always is hardly ever, if ever, selected, which means it's the obvious one that people are leaving out of the logic behind, except which answer you're going to choose. So by having 3-answer options, it's much easier to create two very viable distractors, of course, and then the one answer. So many certification boards are moving to that and finding that it's a much better way. It's not necessarily specific to DEI stuff, but it's still very important.
So is it better because it differentiates the knowledge better, or it gives a better opportunity to? Okay.
Yes. Yes, because it is much. When you work on item writing, it's a much more difficult skill than most people would realize. I didn't really know how challenging it would be, but you're really wanting to test for that knowledge and ability to the higher level thinking. This exam is not built much on recall and definitions. This exam is really testing critical thinking, reasoning, and so you really want to make sure that the candidate taking the test has studied the domains of competency and the ethical standards and knows how to apply those. And so by having the 3 very good options, 2 of which are distractors, is a much better way of discerning how skilled that practitioner should be or is. The other thing that's really significant and important to understand about certification exam is that we're testing for minimal competence. A certification exam is not, this is the basic certification exam is not an advanced, it's not for advanced practice or anything specialization at this point. So we're very specifically just looking for minimal level competency in passing the test. So then, but back to the DEI concepts. The next thing that we really focused on was the creation of a Justice, Equity, Diversity, and Inclusion Committee. And they have been very, very busy in this since this past summer. They have created a position statement for PACB, which it's in a series of pages that'll be launching on our website in the very, very near future. They've also created a scholarship program. And the scholarship program supports they're similar, but still 2 kind of separate groups. So advocates that reflect any of those areas of diversity, such as socioeconomic status, ethnicity, race, LGBTQIA, individuals with disabilities, that would all be sort of one group that could apply for the certificate or for the scholarship. But the other area, it kind of takes care of the other groups of folks that are advocates that are working with underserved population. So that is defined more as they work with populations that have received fewer healthcare services. They encounter barriers to accessing primary healthcare services, have a lack of familiarity with healthcare delivery, or face a shortage of available providers. So advocates that are working in that area can also apply for the scholarship.
And how does that work in terms of they apply for it to cover the time that they are spending with their clients?
No, it's just because they they can apply for the scholarship. It doesn't
To take the exam.
to take the exam.
Oh,
Yes.
got it.
Those are the
Okay.
two categories to apply.
Okay, got it. Sorry, I misunderstood.
And then to support that scholarship program, we have created a lapel pin, which is a tangible symbol of the achievement for anyone who's actually earned the BCPA credential. PCB really believes that everybody deserves access to an advocate or someone that can help them navigate the healthcare system to ensure that their rights and needs are respected. And so that's why we established the scholarship program to encourage diversity in that pool of professionals that hold the BCPA. And the sale of the pins, 100% of the profits from the sale of the pins will support the scholarship fund. And the JEDI committee will be, or the JEDI committee, we have, that's our own internal acronym, and we're not using it externally. The Justice, Equity, Diversity, and Inclusivity Committee is will be reviewing and making decisions about who will receive the scholarship. And then finally, we have the last area is the addition of a new CE category, and that is both for sponsors of CE and for advocates who have the credential. And so the mission, of course, is to maintain a quality certification program. And so we also believe that our advocates should reflect the communities that they serve. And that means essentially demonstrating cultural humility, providing compassionate, person-centered advocacy, and then, of course, standing against all forms of discrimination and in support of underrepresented or marginalized communities. And so, beginning with advocates who earned the certification in 2022, they will be required to demonstrate that they have completed 3 hours of approved continuing education in the area of justice, equity, diversity, and inclusion. And that's 3 of the 30. So we have 30 hours that are required, 6 are in ethics, and then 3 will be in the DEI area. Providers of CE can qualify for pre-approval. And let's see here, I'm looking for my list of what's qualifies for. Okay, so activities, a sponsor like HealthAdvocateX can submit a program for,
And I just put in the chat, so shameless plug here. We're hosting a screening of the film Race to Be Human, which is all about race and racism. It's a 46-minute film, and then we're following it up with this amazing panel. And I think Nicole Rochester is online today as we're speaking in community conversation. She is joining a fantastic panel that includes her. She's a patient advocate and pediatrician doctor. And then we have Nwando Anyoko from Chief Health Equity Officer at Swedish Health Services, and Annie Reisner, who's a former patient advocate. So I hope that everybody will join us for that special screening. And it has been approved for the JEDI 1.5 CEs. So I just wanted to throw that in there while we were while we were talking.
I'm certainly glad you did. but anyway, sponsors that want to submit their content for the JEDICEs, it just needs to be a program that reflects or discusses or in some way assesses the current state of bias, racism, and discrimination, includes representation from diverse speakers, incorporates social determinants of health. So it's, you know, it's pretty wide open in terms of the specifics, but it needs to be a program that's focused in some way on teaching some of the concepts associated with justice, equity, diversity, and inclusion. So, I mean, that's basically what PACB has been up to. It's a big focus of the work that we're doing right now, because we recognize that there's still much, not only much to be done, but much that is needed in the way of educating our advocates appropriately. And so we're really honored and grateful that you asked us to be on today, and we can share that information. I'm certainly open to any questions you might have.
Yeah, and as we're waiting for questions for both Dale and Danielle, I just want to say and reemphasize something that Danielle talked about, which is, you know, why is the health advocacy, patient advocacy community so focused on these areas? And you heard from Danielle is that we have data, not only logically, but we also have data that our health advocates who are currently practicing, there's a big gap in their knowledge and application of knowledge to skill building in this area. So it's really critical that we all as a community continue to focus urgently on education and opportunities for discussing these issues of diversity, equity, inclusion, access. So anyway, we're really glad that you've done all this significant work, and you know, look forward to working with you on also including additional programming. And somebody just said, Marcy, Eventbrite says 1 CE rather than 1.5. Thank you for pointing out that error. We will definitely be correcting it because it has been approved for 1.5. So that must have been a typo. So thanks for Marcy for pointing that out. I also wanted to mention or remind people that HealthAdvocateX will be launching an X Center. And the idea behind the X Center is to focus on a underrepresented or not very well categorized topic through the lens of health advocacy. And our first X Center will be focused on transgender education and health. And so we're working with Dr. Melinda Johnson out of Indiana University on this program, which will have 4 modules that take us through various different aspects of transgender education, health, access. And we are also looking to identify advocates who either have experience or have worked with this population to make sure that when people are coming to the X Center, they can connect with people who are experienced and knowledgeable in this area, because it's not a lot of people who do this work. So if you or someone you know is interested or has experience, if you could contact us at info@healthadvocatex.org. We're looking to launch the X Center here in the next couple months, and we'll be refining it over time. But if you're interested, please contact us because we'd love to work with you. Okay, I just want to say, let's see. So from Christine Van Haren, Danielle, can you repeat the first cohort of advocates that are required to have 3 CE credits included?
So those that earned the certification in 2022, their renewal will be in 2025. That's the first cohort that will be required to submit the JEDICE. And any of you can submit them at any point. You just won't be required to submit them. The other thing that is interesting, and I think it's important and significant, if it qualifies for JEDI, it's also going to qualify for ethics. So even if you don't need the JEDI for another year or two, if you take those programs, submit them as ethics instead, because they will qualify for ethics. That's sort of the general ethics, and then JEDI is sort of a specialization underneath ethics.
Mhm.
So it's
But it
just
qualifies in both categories.
qualifies in
So
both categories, yes.
yeah, that's great. And Nicole, thanks for popping in on the chat, saying thank you for prioritizing JEDI education and awareness for advocates. Health advocacy is a key tool to achieving health equity, and we're going to be hearing from Dr. Rochester. We're so appreciative of her and to her for joining us on this expert panel on March 27th. So I hope to see a lot of you who are tuned in at that program. Let me just make sure here. Let's see.
Robin, I just
yeah.
wanted to chime in and thank Danielle and Heidi because they're also involved in the coalition of health advocacy, the leaders that have been meeting for the past couple years, and they bring the education piece to the table, which is really important for our group. So just wanted to mention that.
Agreed. And for all of you who are advocates and who might not be, that's a great point, Beth, who might not be as behind the scenes on supporting and growing the industry of professional health advocacy, Danielle, Heidi, and team they've just done a tremendous job. We have so much respect and appreciation, because 10 years ago, when this field was kind of getting off the ground in earnest, we didn't have the credential and we didn't know if it was going to work. And I think, one of the things I'm curious about, Danielle, is how many board certified patient advocates there currently are. And what is the trajectory? Like, what are you seeing in terms of trends for new people coming in to take the test? Like, how is this growing over time?
That's an interesting question. It actually varies more than you would think. And I'm really looking forward to the day when we have enough data that we can actually do some better trend analysis.
Mm-hmm.
We have over 1,100 now, and we're currently in an exam cycle. So we'll be adding to that at the end of the cycle, which closes on the 1st of April. And it's the one trend that we can say is the people that take the exam at the beginning of the cycle tend to do very well. And the people that put it off till the very last part of the cycle tend to do much worse. So there is a very clear pattern that those that have the confidence to go in and get the exam done and taken tend to be the better prepared candidates, which is
so let me understand this. So you have a spring and a fall.
Mm-hmm.
And so there's a higher percentage of people that pass the test in the spring than in the fall.
No, I'm saying it's a 4-week cycle.
Okay.
So this time,
Okay.
it started on March 4th, ends on April 1st. And the people that will take the exam in the first week to 2 weeks will do much better than the people that take it in the second 2 weeks. And that trend has tended to pan out. And I think that's more a psychological kind of thing and also a preparedness kind of thing. But as far as the trending from who registers, when, the other trend we see, which is not something we really like, is people are signing up for everything later and even closer and closer to the deadline. That seems to correlate more with just the general uncertainty of everything right now. And I don't know that there's a whole lot we can really do about that. It's just sort of the state of the world,
Right.
which makes it much more difficult, I think, for planned trajectories. But overall, we feel really good about how everything's going. We're continuing to grow.
Good.
We'll be publishing the very last bit of the job analysis study, which will actually be the linkage of the tasks back to the domains and the ethical standards. And that'll, as soon as possible, it's just an incredibly detailed study, and a great deal of work goes into that. But hopefully that will be in the very near future. And then we're also, looking at other ways that we can work with, and of course, we're a certifying body, so we're not an education. We don't do education. That's not our role. But our role, of course, is to work with and inform all of the organizations out there like HealthAdvocateX who do provide education and all of the important support that makes for a population of candidates that are available and ready to sit for the exam. So we all are part of the whole process and the cycle, and are really grateful. We know HealthAdvocateX does fantastic education, and we love working with y'all.
Thank you.
Great work that you're doing.
We enjoy working with you too, obviously. You can see it's a mutual love fest. I also wanted to just mention, and Beth might have a little more information on this, that Chicago, which is the coalition organization of health advocate organizations, recently supported a study of advocates and patients. And I'm not quite sure when that is coming out. Maybe you, Danielle, or Beth know a little bit more about that, but it seems like this group might be interested to just keep their eyes open for that to be released.
I don't know that we have a firm release date for the study. I do know that we have preliminary results from that, and we also are working with a medical writer, and she is preparing a formal report, a white paper that will be issued. I don't know, Beth, I don't think, or Heidi, do you have any other thoughts about time on that?
I think that the hope was that we would have it available in the fall for potentially for a meeting to submit it at. So again, we don't have those dates, but as soon as we have them, we're going to make them public. So, but it's exciting because the survey it was patients, advocates, providers, anyone who's had a touch with advocates. So I think it'll be really helpful to have that data, more information. It's always helpful.
And as we're wrapping up, we have just less than 2 minutes left. I just wanted to see, Dale, if you had any remaining thoughts as we closed out our community conversation for today.
Well, I do have a remaining thought, but there is Sandy Johansson put some comments in the chat about the effectiveness of masking and what they saw at Highline. So everybody's vaccinated, 65 and older community, and that when they had staff, and once they didn't mandate staff and resident vaccination or masking, they had COVID cases in the independent living for the first time. So I think we'll see a lot of those community types of examples. And I do want to make it clear that you cannot get Paxlovid without a prescription. So you must be vetted through your provider. And that's why that talking about it ahead of time makes sense. Because if you're on an ACE inhibitor, for instance, and you cannot, I think it's the ACE inhibitors and some of the lipid drugs that you can't take Paxlovid with, then ahead of time and you're not worrying about that. So thank you, Sandy. It is important to stress that that is prescription and it should be reviewed with your provider. And that would be something you could do when you're not in the middle of an infection. And just thank you, Danielle. I really, the DEI work is super important to my heart. And I the more organizations that put a focus on it and live it, I think is the way we're going to get there, very slowly, but get there. And I really appreciate that it's includes, of course, the BIPOC population, the people of color, but more than that, and more than that. So disabled people is a group that do not get attention and do not have access and are not treated with respect in the similar way. Our substance using population has the same, they're probably the worst, actually. And if you happen to be Black or Native and substance using, you get no respect and very poor care. So the fact that you've had the broadness to include that in the LGBTQ plus population is just laudable. And I really appreciate you and your organization for doing that, for highlighting it for us today.
Thank you very much.
So thank you so much, Danielle, Dale, and for all of you for joining us. And we hope to see you at the March 27th Race to Be Human film and post-panel discussion. And so just please register and share that information also with your colleagues and friends. Thanks so much and be well.
Thank you.
Bye.